Percutaneous tracheostomy is a minimally invasive alternative to conventional tracheostomy. This is a bedside surgery performed in patients expected to require mechanical ventilation for longer than 3 to 7 days, and time is decided on a case-to-case basis. This technique was popularized by Dr. Pachalia, and this was actually his accidental invention in his early 70s. And there are two methods for this PDT. One is Seglia method, developed by, I already explained it. This uses graded dilators and currently the most popular method. Another technique described by Crick et al. In 1990 uses a one-stage dilatation technique using a modified Howard-Kelly forceps as the tracheal dilator. Okay, it uses a modified Howard-Kelly forceps. What are the advantages of percutaneous tracheostomy over surgical tracheostomy? This is a relatively simple technique suitable for trained staff in the critical care setting. This does not require an OT and the procedure is usually performed under local anesthesia. And it forms a stoma between the tracheal ring, resulting in reduced blood loss, as there is usually no disruption of the blood vessels. And also, any tendency to bleed after the procedure is also minimized. The infection rate for PDT ranges between 0 to 3.3%, whereas those for open tracheostomy have been reported to be as high as 36%. There is a small and neat stoma of the dilatation tracheostomy, so it generally results in a more cosmetic scar. And the complication rates are almost the same of conventional, except a very low rate of immediate or intraoperative complications. Then percutaneous tracheostomy kits are pre-prepared kit that contain a sterile drape, syringe, lidocaine 1% local anesthetic, introducer needle, guide wire, tracheal dilators and a tracheal loading trocar. And commercially available kits are there. The Blue Rhino and Romsons are commonly used. We need to have an airway backup plan in case there is a loss of airway while doing the procedure. And what is the technique of percutaneous bronchoscopy-guided percutaneous tracheostomy via Seglia technique? It is the safest technique with the fewer complications. Two physicians are required, one to perform the bronchoscopy with the endotracheal tube and second to perform the percutaneous procedure at the neck. In addition, we also need a nurse to give sedation medication, monitor the blood pressure in every 2 minutes and telemetry monitor along with the pulse oximeter, and also we need a respiratory therapist to manage the ventilator. It's better to do an ultrasound to locate presence of a high innominate artery. And before the procedure, connect the bronchoscopy adapter to the endotracheal tube and inspect the airway with the help of a bronchoscope. The patient positioning, it is supine with the neck extended by placing a sandbag under the shoulders and a head ring. Identify the landmarks, mainly the thyroid and cricoid cartilage and also the suprasternal notch. Usually we put the incision as in an open tracheostomy in the second and third tracheal rings. After identification, prepare the surgical field with chlorhexidine or a betadine and cover with a sterile drape to expose the neck area. Then the tracheal lumen is fully visualized and insert an 18 gauge needle into the space between the second and third tracheal ring, and it should be monitored intraluminally with the bronchoscope. The endotracheal tube cuff is deflated and a respiratory therapist start pulling the endotracheal tube to the proximal end of the trachea, that is in the subglottic area, and then the cuff can be reinflated. Okay. After that, use a Seldinger technique to place J tube over the needle and remove the needle and make an approximately 1 cm skin incision halfway between the cricoid cartilage and the suprasternal notch, and dissect the subcutaneous tissue to facilitate positioning of the tracheostomy tube. And with the J tube guidewire in place, put sequential dilators. to create a soft tissue channel and an opening in the anterior wall of the trachea. And after that, once the tracheal opening is adequately dilated, insert the tracheostomy tube from the kit, and the percutaneous tracheostomy is in place. Again, the cuff is inflated. Then perform a bronchoscopy through the newly performed tracheostomy to confirm the position in the carina. Usually the end of the tube and the carina should be around 1.5 to 2 centimeter distance. And there are some safety tips. One, this is a teamwork. So involve multiple trained personnel, as I already explained. Never remove the endotracheal tube before the procedure. So always deflate the cuff and pull it into the subglottic area, and then re-inflate and put the bronchoscope through that and inspect. And when you put the needle should be angled caudally. If it is going directly backwards posteriorly, there is chance of injury to the posterior tracheal wall. Then after the PT is in place, inflate the cuff and confirm its presence by the bronchoscope. So intraoperative complications are mainly hemorrhage, then a pneumothorax and pneumomediastinum, as in a conventional tracheostomy. And there are some disadvantages like increased risk of posterior tracheal wall injury and risk of anterior tracheal ring fractures.